So some of the techniques in order to prevent the development of hypotension during dialysis, one is cool dialysis, of course. So decreasing the temperature of the dialysate will promote vasoconstriction. So it is because the blood that is returning to the patient is much lower in temperature compared to the core body temperature, leading to or promoting vasoconstriction. So at least the patient will be the blood pressure will be stable during dialysis, but not for all patients, of course. Especially for those who are decreasing the body temperature once the BP already decreases. So during hypotensive episode, most likely the patient is already vasoconstricted. The vessels are already vasoconstricted. So doing cool dialysis during that time gives no benefit to the patient. So another thing is increasing the sodium concentration during dialysis. We have sodium profiling. Why? What happens during sodium profiling? So we increase the sodium concentration initially. For example, we prescribe 145, then the machine will eventually decrease it to 143, 141, 139, 138, then 136, for example. Remember, during the first hours of dialysis, I mentioned earlier about the increased clearance of solute. So at least during the early hours of dialysis, you are increasing the sodium concentration inside the vascular space. So what will happen is you can draw more fluid from intracellular to extracellular compartment, leading to fluid expansion during the early hours of dialysis. And that's the reason behind that the sodium profiling is also done together with UF profiling. At least during the first hours of dialysis, you can remove more fluid. 1.8, 1.6, 1.3, then most likely 1.1, then up to the lowest point. Okay? Again, we have sodium profiling, for example. We increase the sodium concentration initially during the initiation of dialysis or initiation of treatment. For what reason? Increasing the concentration of sodium will increase the osmotic gradient, or increase the concentration of solute within the intravascular space, leading to increased movement of fluid from interstitial space into the intravascular space, or from intracellular space into the extracellular space. And that's the reason behind that sodium profiling is most likely done with UF profiling, because increasing the sodium concentration will promote volume expansion, and we can remove more fluid during that time. So at least we decrease the chances of developing hypotension. Another thing to consider is, please consider your UF rate per hour. So like for example, as I have mentioned earlier, if your patient weight is 7 kilograms, the max UF as calculated by 13 ml per kg per hour is 3.6. So the UF rate per hour is around 910 ml per hour. I don't know if it's correct, but it's 910 or 900 ml per hour. So what happens is, it is calculated by 4 hours. So most of the staff nurses, for example, they will encode in the machine 3.6. Okay, 3.6. So they are removing per hour of around 900 ml per hour. It's okay. But the problem is sometimes we are decreasing the time. I don't know for what reason, but for the reason, for example, if you want to terminate earlier, so if you decrease the time, because this is calculated for 4 hours, so if you decrease the time, you are also increasing the UF per hour. So what will happen is, you encoded the right max UF for the patient, but how much you are removing per hour? You go beyond what is the max ultrafiltration per hour if you decrease the time. So if you decrease the time, decrease the UF also, the max UF, because this will contribute to intradialytic hypotension. Another intervention to do to decrease the chance of developing intradialytic hypotension is ISO-UF, isolated ultrafiltration. Actually, this is discovered by Dr. Jonas Bergstrom accidentally. So this is a nephrologist, so Jonas Bergstrom. They have this unit or dialysis unit in which they have a patient who always develop hypotension during dialysis. Every time the patient is doing dialysis, he or she will always develop hypotension. And then there was one day that the patient did not develop hypotension. So they are surprised. What happened? What is the special thing during that day that the patient did not develop hypotension? So they tried to investigate what happened during that time until they discovered that they forgot to turn on the dialysate flow. So meaning to say, what they are doing during that time is they are only removing fluid via ultrafiltration without dialysis, and that's the time they develop this isolated ultrafiltration. So what happens during ISO-UF is, if your patient gains 4 liters, for example, and you increase the removal within the first hour to 2 liters, for example, you remove the fluid, but you retain the solute. Retention of the solute will increase the osmolarity. So what will happen is you will also draw fluid from intracellular to extracellular, from interstitial to intravascular, meaning to say while you are removing the fluid during the first hour or during the initiation of ISO-UF, you are also expanding the intravascular fluid volume. And that's the reason behind the patient most likely will not develop hypotension during dialysis with ISO-UF. At the same time, there was a theory about heat generation during diffusion process. So heat generation during the diffusion process will lead to vasodilation that will eventually lead to hypotension. So those two are the common factors why those patients that are placed on isolated UF as the modality of treatment will not develop hypotension during dialysis. Okay. Last thing to remember, how about cardiac stunning? Why some patient who develops hypotension will develop cardiac stunning or suddenly they collapse? Severe hypotension, what's the reason behind? So during ultrafiltration, sympathetic response will kick in, of course. You decrease your intravascular fluid volume, the heart rate will increase. Okay, heart rate will increase. It's okay because it's just a compensation for the decrease or the decline in circulatory volume. It's okay. But the problem if the heart rate, the tachycardia or increase in heart rate is prolonged. Prolongation of tachycardia, for example, plus fluid depletion will lead to myocardial ischemia. Right? You have increase in heart rate. You are removing fluid. What will happen is it will lead to myocardial ischemia. And in order to protect the heart, we have the mechanism or the reflex we call the Zolgerish reflex. The Zolgerish reflex. So initially, we have sympathetic response to compensate the loss of fluid, the loss of total peripheral resistance or systemic vascular resistance. But if this is prolonged, for example, heart rate is prolonged, tachycardia is prolonged, for example, with ultrafiltration, it will lead to myocardial ischemia, and this will cause damage to the myocardial tissue, leading to infarction, for example. So in order to protect the heart, parasympathetic response or parasympathetic nervous system will kick in or will be stimulated to decrease the heart rate suddenly. And that's what happens during cardiac stunning. Increasing the heart rate, you have increased heart rate just to compensate the loss of peripheral resistance or systemic vascular resistance, but eventually it will lead to myocardial ischemia. In order to protect the heart, actually the Zolgerish reflex is a cardioprotective reflex in order to prevent myocardial infarction or ischemia in the myocardium. So afterwards, the patient will develop cardiac stunning and the patient will suddenly collapse. So this is one of the mechanisms why we saw some patient who develops who has severe hypotension, and it is very difficult to correct because parasympathetic nervous system was already stimulated. And you will notice this one if your patient has severe hypotension, even if you give a lot of fluids, for example, for volume expansion, and still the patient is hypotensive.